Now, we are truly, truly fortunate to have two distinguished leaders in the field of multiple sclerosis joining us tonight. I'm excited. And I believe so that everyone else who is now online watching this also very, very excited. So, first of all, Professor Gavin Giovannoni is a pioneer clinician and researcher whose work has been pivotal in advancing our understanding of MS, including the concept of smoldering MS. So we are very grateful and thankful, and its implications as well for progression and treatment. His contributions have shaped global MS care and research. He is the most influential person in MS world, and he runs his self-management platform called MS Selfie. You're probably very much aware of that. Another professor tonight is Professor Jeremy Hobart, an exceptional clinician and academic. We used to work together when I was in, I used to be one of the neurologists in Plymouth. Now I'm at Torbay. But he was my supervisor, my mentor, and we still continue having discussions and I continue having supervision, which is amazing for me. So he's widely recognized for his patient-centered approach to care and his expertise in developing outcomes that matter to people living with MS. His work bridges the gap between the research and the real-world clinical practices. So both Professor Gavin Giovannoni and Professor Jeremy Hobart need no further introduction, as their accomplishments and leadership in the MS community speak for themselves. So let's bring them into this conversation. And I would like to just give you a bit of a heads up and explain the main focus for tonight and for people who joined us later. We're talking about the smoldering MS and its most pressing and unexplored topics that we want to talk is the concept of smoldering MS. What is it, and why it matters. It's important for us all to know. Then we would like to talk a little bit about the neuroplasticity and its potential offer to hope and also brain resilience in MS. We know the hot topics and your concerns if you're living with MS and many other healthcare providers who works in multiple sclerosis. It's the gaps in MS care and including the shortages of the specialists and how we might address them. We will bring some ideas here, you will see. And also we'll touch a little bit on bold ideas, forward thinking, innovative approach and discussions on the future of MS diagnosis and management. So as you can see, we have carefully crafted the plan to ensure that it is going to be an inspiring and thought-provoking discussions for the MS community. So without further delay, let's begin and let's talk about the smoldering MS to start with. So first, perhaps maybe Gavin, I would like to bring you into this conversation as you're the bravest out of all of three of us. I would like to know a little bit more and understand the mechanisms of the smoldering MS and its role in progression.
Yes, so thanks, Agni. I mean, the smoldering term actually is not new. It was actually probably used for the first time in the 1970s by two pathologists, John Prinius and Cedric Rain, and they looked in the brains of people who had died of multiple sclerosis post-mortem, and they'd seen these little lesions, what they call the smoldering MS lesion, and it was really a lesion that had this cell called the microglia and was still active even though people had had the disease for 50 years, when they had passed away from the disease. And that was called the smoldering MS lesion. And then George Ebers, who's a neurologist from London, Ontario, he had made this observation in the 90s that relapses, the attacks that people have, contribute very little to disability in MS. And actually, they don't predict disability at all outside the first 2 years in their data set. And what he was seeing was this gradual worsening that people experienced. He didn't call it smoldering disease, and nobody really accepted George's ideas. And so we then rediscovered them. So one of the observations came from the natalizumab Tysabri data set, where despite most of the people being rendered free of attacks, relapses, were getting worse. Getting worse with time. So, and that was referred to as PIRA, progression independent of relapse activity. Now, the problem with the term PIRA, it's something that happens in clinical trials because you have to get monitored every 3 months, and there's a specific way of defining what progression independent relapse activity is. And at the same time, there was lots of other evidence emerging, to say that that wasn't adequate to explain this concept. So we put together this term called smoldering multiple sclerosis, which is an umbrella term, and it incorporates many things. It incorporates what people with the disease talk about. They often describe themselves as getting worse without having attacks, and their MRIs may be stable in terms of new lesions. We can see it on MRI scans. We can see it with biomarkers. So there are different ways of measuring it. So the term smoldering actually captures the hidden symptoms, or the symptoms that people with multiple sclerosis have that we don't see, the ones we can see, and various markers on MRI. So this is what I think the disease is. And the more I think about it, the more I think that the attacks people with multiple sclerosis have, relapses, and the lesions that come and go, is not what MS is. That's actually the immune system's response to what's causing the disease, I think, and the disease is in the brain and spinal cord. And even if you remove those attacks and those what you can see on MRI scan, there's still stuff going on inside the central nervous system in the brain and spinal cord, and that's the concept of smoldering MS. Does that make sense?
Yes, yeah. So almost like for me, it's like we're finally now giving a name for the domain in MS that is invisible. So a lot of people come and we say, well, you haven't got a new relapse, you haven't got new MRI scan changes. But then the patient who comes to you, they feel like things are changing, but
yes,
not necessarily. Yeah.
Yes, I don't like the term invisible, because invisible means you can't see it. And I think we can see it. We just got to use better tools. And this is where Jeremy should come in. One of the things we now know is that lots of the clinical tools we use to monitor MS, the so-called EDSS, the Expanded Disability Status Scale, are just not good enough to capture this process. So Jeremy, maybe you wanted to talk about why we need better tools to capture this process.
The ability to assess and measure diseases very well is increasingly important as we move beyond the standard methods, and the methods that we've had have been around for a long time, and they're very insensitive to differences, and they're very insensitive to the spectrum of problems that people have. And that's why we need to move to a new era of instrumentation, enabling people with MS to complete these, as it were, questionnaires, from which we can derive information that gives us a more accurate understanding of their disease. And we've seen this, and I'm sure many people on the in the audience will have experienced situations where they are getting worse, but the parameters that have been used to assess them, that is their standard MRIs and their standard disability measures, don't reflect that, and that always leads to a very difficult conversation and a very disheartening situation for people.
Absolutely. And I think when we are not asking or not measuring, so that becomes invisible. Like nobody knows about this point of view. But actually bringing more innovative ways of assessing, asking the specific questions about this domain in multiple sclerosis, and you can then highlight a lot of issues. But I think understanding of the process and knowing that from real people living with MS, this is where the all information and data that then could drive us to develop measurements, to develop right treatments. But knowing what it's like to live with smoldering MS is the key step, right, Jeremy?
Yeah, I think just as of yet, we haven't done the hard yards of this, which is the detailed qualitative work with people with gradual worsening MS. We do lots of cross-sectional work with people, but not longitudinal understandings of how their problems are changing and evolving over time. So that's a piece of work that is just started, and that maybe I'll mention a little bit more of a bit later.
Yeah.
Agni, can I make a point, because it's
Yes.
often brought up?
Yeah.
We do know that this process begins very, very early in the course of the disease.
Mm-hmm.
So that's the other thing. Even in people who don't have a diagnosis yet, asymptomatic, we can detect markers of smoldering disease. So this would be asymptomatic MS in the sense that the individual hasn't any obvious symptoms. You can find markers of the disease. And the other point I want to make is it's quite clear not everybody gets smoldering MS, because a significant number of people who get to post-mortem in old age as part of studies and found to have MS in their brains at post-mortem. And there was this big study in Denmark where everybody used to have post-mortems, and they found that a quarter of the people that had MS at post-mortem were never diagnosed in life. So what probably happened in those people, whatever caused MS, their own bodies cleared it. And we also know in life that there are people who have, in retrospect, what we call benign MS. They get to old age with MS, with no disability, and they've been stable for years. So there's something about those people that clears the MS, and they don't have smoldering disease. So I just want to stress that not everybody with MS necessarily gets smoldering disease. There's something, some people obviously deal with the disease and clear the disease or whatever it is themselves.
We are interested, can we see the effects of smoldering MS on MRI scan, on the conventional MRI scan? A lot of people ask this question. Can we dig deeper and understand the processes? Can we see it? Maybe Gavin?
We don't look for it in routine scans because the kind of measurements we look for are not reported by our radiologists, because they need to take those images and process them offline, and the current scanners don't do that. But if you take the MRI scans and you do serial scans, you'll see accelerated brain volume loss, the brain shrinking a bit faster. It actually happens in everybody because aging causes that. But in people with multiple sclerosis, there's a more rapid brain shrinkage, and that's, we think, is smoldering, a marker. And then some of the lesions that we see in multiple sclerosis get bigger. They call them slowly expanding lesions. And some of them have this rim of iron around them with a magnetic resonance scan, MRI scan. You pick up this iron, and we think what's driving those lesions is some of the pathology that we think is smoldering. So yes, there are techniques on MRI scanning to measure these processes, but as of today, they're not in routine clinical practice. Jeremy, do you think that will come into routine practice? Because the diagnostic criteria for MS are going to change. They're going to include paramagnetic REM lesions. So,
well, I hope so, Gavin, because we're selling people with MS short at the moment in terms of the evaluations that we can do at important stages in their disease journey. But I guess that takes us into the arena of care delivery and the ability to deliver these types of imaging processes widely for people and regularly. I guess the other thing that then comes in is whether there are potential blood measurements that could be used to give an indicator, and there's a lot of interest in neurofilament as an indicator of an active process within brains and spinal cords. And if we could roll out those sorts of measurements and they could be proven to be valuable, then it would be a much easier way of monitoring people on a regular basis. And there is some talk of capillary level. So much like diabetics use finger prick measurements to measure some of their blood levels, then that may become available at some stage with neurofilament.
Wonderful. This is what we want to hear. The easy, not a lumbar puncture, but the bloods that we could easily extract from patients, even if it is a pinprick, to check for these levels. That would be fantastic. And on the other hand, as you can see from the MRI scan, we can tell there is an element of the smoldering MS, but almost like in retrospect. Nothing is that like we can predict, or there's nothing that we could see right now. Sometimes we do, but not always. And I think also we have to emphasize the communication gap, how we communicate as a healthcare providers with our patients, and how we extract the information from the patient. Jeremy, maybe it's your sort of way of thinking, patient reported outcomes and challenges, and the importance of identifying the smoldering element. Can you dwell a little bit on this sort of communication, and how can we get this information from the patient?
Yeah, I think so. Gavin and I were at a recent meeting, and there was a presentation from a European survey of people with MS, and over 50% of people said they found it difficult to articulate their symptoms to the healthcare professionals. And on top of that, healthcare professionals usually don't have the time slots within their clinics to give people the time to work through the understanding of the degree of problems and the breadth that they have. So we do need methods to assist people in those consultations, and I guess that's the concept of assessment, and part of the role of detailed qualitative work in people with gradual worsening in MS is giving us the degree of breadth and depth of that information to enable us to construct instruments that we can use in clinical practice to assist people with MS in communicating with their clinicians, and clinicians understanding the breadth and depth of problems that people have.
So Jeremy, do you have any concrete ideas? How can we do that? Is it like 4 questions questionnaire that we can bring into the clinics and get some sort of extra questions during the consultation that we could feed that to the research and then assess as yeah?
Yeah, I think certainly those sort of almost structured interview type processes can be really valuable for people in terms of helping them to articulate through what is essentially other people's experiences the degree of problems that they have, and that can then feed into clinicians. Now, how that will work out in real time is a little bit uncertain, but the concept of structured information is a way to assist that communication gap that you've highlighted as important.
Are there any clinical trials planned in the future to look into this specifically?
Not in terms of clinical trials, I don't think, but certainly in terms of clinical studies to do detailed qualitative work in people with MS, and we are involved. Both Gavin and I are involved in one at the moment, looking at people with smouldering MS. We're actively recruiting, so I can show a slide at the end that gives people the parameters that we have for recruitment, and also the email and web links that they might wish to look at.
Okay, there is a hope, people listening to this. There is really a hope that we could all as a team contribute and actually be active participants in this clinical trial that collects the data, and it only enhances the better understanding what is the smoldering MS. We know details, but we want real world, real lived experiences, and that's coming from you living with MS. Now, brain is affected by numerous amounts of lesions living with MS. Brain is affected by a neurodegenerative process. Brain is affected by smoldering element of MS, and that's a sort of a chronic inflammatory diffuse process. But there is a hope that brain has got a huge neuroplasticity, a capacity and a resilience. And let's talk about this and give a bit of a hope to the audience. So Gavin, briefly explain the science of neuroplasticity and its potential in MS.
Well, neuroplasticity really means that what's left behind, in other words, not irreversibly damaged, can adapt to the damage and take over function. So it's actually like repurposing existing pathways or to recover function. That's what I because plasticity can occur at multiple levels, but I'm talking at an overview of plasticity. And there are many mechanisms. I just want to let people know it happens at the synapse at the end of the nerve fiber. It happens at the axon, and it also happens centrally in terms of the surface of the brain, what we call cortical plasticity. But I think the bottom line is, if you've lost a function, can you retrain the brain to regain function? And I think there is ample evidence of the ability of plasticity. And I don't know if Jeremy is going to talk about a particular. There's a new drug that's just been shown in a phase 3 trial to target smoldering MS and slow down the worsening that occurs independent of relapse activity. And what was remarkable, and that was actually done in quite advanced secondary progressive disease. These are people that were not having relapses, and the EDSS scores were really high, close to 6 on average. And what was remarkable is that the people who were on the active therapy, there was a significant improvement in function relative to the people on the placebo, the dummy drug. So even in people with advanced disease, there's this ability for the nervous system to recover. But I think what's really, really important, Agni, is what we don't do enough of is it's the old saying, if you don't use it, you lose it. So when people are losing function in a pathway and they're noticing that things are deteriorating, they need to have targeted rehabilitation because the stimulus for recovery of function is actually physical activity or rehabilitation. And same with cognition. If your cognition is not as good as it should be, doing cognitive rehabilitation improves cognition. So it's all about the stimulus. And we haven't up until now incorporated what I would call, I say targeted rehabilitation because there's no point in rehabilitating a fully functional pathway. I mean, that's called pre-rehabilitation, but we should have targeted rehabilitation in pathways you want to recover function in trials. We just don't do it in trials.
Yeah, so if we combine the disease-modifying therapy, and one of the promising that Jeremy Hobart is going to share his few slides on this new drug that is in the market, and is fantastic in controlling the disease and the progression and element of the smoldering MS. But also if you combine that with a lifestyle approach, and as Gavin just said, targeted, personalized lifestyle, you are really on the good books. You really controlling the process and enhancing your brain neuroplasticity and brain reserve. And if you look at the Prof. Krieger's model of topography and brain reserve, we don't want to waste that pool of water. We want to keep that volume of the brain. And if we combine these approaches together, I think we are achieving the goal here. So Jeremy, over to you to explain a little bit on drugs available for smoldering MS.
Shall I?
If you could share your slides, that would be wonderful. Or
yeah. So Andrea, you'll have to give me authorization to share, I suspect.
I've just had a look on yours because you're on a different email address. I'm not sure that I can.
Oh, okay then. Well, then I can just talk through them for people. So
yes.
So there is a drug called tolibrutinib that has been studied over the last few years, and the results were reported at the big MS meeting in September in Copenhagen. And that big MS meeting is called ECTRIMS. It's a funny name. It's the European Committee for Treatment and Research in Multiple Sclerosis. But essentially, this was a study of a new drug in people with gradually progressive MS, but who did not have relapses, essentially, and acute inflammatory activity. And this type of drug is called a BTK inhibitor. And that stands for Bruton's tyrosine kinase inhibitor. And it's essentially a drug that blocks an enzyme that is involved in various pathways. And in this large international study, they randomize people to either the treatment, that's tolibrutinib, or to a dummy drug or placebo. And then they monitored people over the subsequent 36 months or so. And the main so-called outcome measure was the time to accumulating progression at 6 months. So so-called confirmed disability progression at 6 months. And the simplicity of the results are that less people got worse, but not only that, more people got better, which is Gavin's point about feeding into the discussion we've had just a few minutes ago on neuroplasticity. So there was a 30% reduction in the proportion of people who got worse over time, essentially. And there was a doubling of the proportion of people who got better during the study. So less getting worse, more getting better, which is a very positive finding. And that this is in people without inflammatory disease, without active inflammatory disease at the time of the study. So we believe these people to have low-grade so-called smoldering disease. And if you look at the treatments to date, the majority of them have been aimed at the inflammatory aspect of the disease, the acute inflammatory aspects of the disease that gives relapses and new abnormalities on the MRI. So this is an enormous contribution to the future of MS care. And this drug has just gone through the FDA in the US and will go through the processes of regulatory assessment in Europe. And then when it goes through that, it has to go through the local processes for each individual country. And for us, that is this entity known as NICE, National Institute of Clinical Excellence, to determine whether and how the drug will be made available to people. Now, the sadness of all these situations is those processes take so long to play out in reality. However, this is a fundamental step in the management of MS, and its future is the finding that a treatment influences this non-active, this non-acute inflammatory nature of the disease, and that, I think, opens the door for combination treatments. So Gavin, I'm going to ask you about what do you think about combination treatments as the future of MS?
Yeah, so I mean, people need to be aware that this particular drug, the way it works, it's got two modes of action. It actually does have an anti-inflammatory effect and an effect on the smoldering processes in the brain, those microglia, those. But I mean, that's going to have to be the future of MS therapies. We're going to have to give both treatments, an anti-inflammatory, and then combine it with a drug like tolibrutinib, or sequence them. You give a potent anti-inflammatory to get rid of the inflammatory component, and then have a switch to this. So this is going to have to be the future of MS. Now that we have identified the unmet need as smoldering disease, and it occurs even though people aren't having relapses and MRI activity, that will be the challenge. So that's the future, yes. And then also, I mean, Agni's raised the point, and I think we shouldn't forget the point that, what we call brain reserve or resilience, the ability to recover function, is important that people treat their brains gently. And we know that poor brain health contributes to early or premature aging. So all those lifestyle factors also need to be put on the table as a management strategy for smoldering MS. I have this philosophy called marginal gains. It comes from the sports world, where if you make little improvements to every aspect of your performance, things overall improve by quite a lot. I mean, Dave Brailsford, the manager of Team GB, the cycling team, he used marginal gains to take Team GB from almost people who could hardly win an event to almost taking all the gold medals in the Olympic Games, and he used marginal gains as his guiding philosophy. And I think the same thing applies to MS. If you improve all the little things, exercise, diet, sleep, getting rid of drugs that are bad for your brain, and all this adds up. This is why we need to promote brain health as part of a strategy for treating MS, in addition to developing combination therapies.
Jeremy, I would like to hear how do you promote the brain health in your clinics?
What we try to do is help people to understand the value of healthy lifestyle and give exemplars of the important planks. So exercise, both physical and cognitive, diet and weight management, smoking, vitamin D, and trying to moderate alcohol intake are aspects of lifestyle. Then there are issues around sleep, well-being, and managing your own mental health. Now, I think it's fair to say we do not get into these aspects to the extent that we would like to, because we don't actually have the capacity to move beyond some aspects of basic care. So we try and signpost people to information, whereas I think it would be much better to run things that are more direct for people than the passive concept of signposting. And I guess that's something where you have put a lot of emphasis and a lot of energy and effort into in your own work.
Yes, I followers and listeners at the moment, I'm very much aware that you are aware of the initiatives around the brain health and healthy lifestyle. So you just find that information, and I just want to emphasize that, you know, one size does not fit all. You really want to explore. Sometimes you do your own research and you try certain methods, and if it doesn't work, you go on to another one. But giving up too early is not reasonable. And as you can see from both professors, they also highlights the importance of living healthy to preserve the brain health, to improve the neuroplasticity and give a capacity and build the nice soil for the DMTs, disease-modifying therapies, to work. And it's so important now, as you can see, that identifying the smoldering MS is super important, because there are drugs upcoming that we will be prescribing for the smoldering MS. So I think, just to add to that, all the complexity, that if we could combine therapies together using anti-inflammatory drugs, maybe smoldering MS drugs, but then some of the DMTs cover both anyway. But I think we also have to think about adding some regenerative agents that probably is a combination of the therapy in the near future. The future is bright overall, and we need more research to confirm this, and then we will be licensing these drugs and prescribing widely. But you know, you as a person living with MS, you're experiencing all that, and I think contributing to the research and providing your own experience and data to smoldering MS clinical trials is crucial, is super important, because that will allow us to understand what is smoldering MS and how safely can we prescribe disease-modifying therapies that are specific to smoldering element of MS. Now, let's move on to another segment. We are very conscious of time. So, you know, people say, okay, you're talking about the smoldering MS and how to identify and what the drugs are available. Everything seems okay. I'm happy to be part of the research, whatever. But then I can't see my team. There is a problem getting access to my healthcare provider, you know, and I would like to spend a little bit time talking about the gaps in MS care and addressing the specialist shortage and timing, that people are not getting seen. That's a big problem. Like, even if they have smoldering MS, how can I identify if we can't see these people? So let's talk about the current status of MS care and workforce gaps. So Jeremy, maybe over to you. What is required for us to improve that?
I think we need to really consider a radical change in the way we deliver care. People's experiences on this webinar and wider, will have variability in the experiences of their care, which will depend on a whole factor of things. But I think it's fair to say that across the country, that and across the UK, that MS care is way below the standards that clinicians would like to be able to deliver and know would be of benefit to people. Now, how do you do that? Well, I think you have to think through the structure of care and how we deliver, given that we have a relative shortage compared to the number of people we have of specialists, and it takes a long time for specialists to come. So part of my belief is that we have, that we should have or could have regional hubs that through which people are fast tracked for their diagnostics and their treatment planning, and then the treatment planning is, as it were, outsourced to their locality with clear guidance for management and monitoring, but they also have access to the central hub for emergency problems as well. And I think that would help us with a number of the challenges we face. In some ways, things are work in a slightly curious manner in that you have to go through a series of hurdles to get to see the people who are likely to help you specifically. And it's the same as pitching up in casualty, where you start by, you may see a triage nurse, then you may see a very junior doctor, then you may see someone who's part way up the ladder, then you may see somebody else, and you may see somebody else, and finally a decision maker comes along. So we have to reverse the way that we deliver care, I think, and make specialist care accessible to people. But the whole thing is so challenging in the current climate that I think there will be a need to change, as we were talking before people joined, is the way that actually care is delivered. And maybe Gavin, you want to come in and talk about the possible need to move to dual mechanisms of healthcare funding.
Yeah, I mean, yeah. So I mean, you know, anybody who reads the political pages of any newspaper or political magazine would come to the conclusion that the current funding model for the NHS probably does need an overhaul, because at the moment it's unaffordable out of general taxation. You know, in most countries, what's interesting is that, you know, the UK, the NHS is now costing as much as other healthcare systems, and the results are not as good. So when you compare it to the Nordic countries, Germany, Australia, Canada, for example, you know, we're not doing as well as those countries anymore, and we're spending as much, if not more, money than those countries. Because and I think one of the reasons is that there's too much pressure at the touch point. So we actually, you know, you could potentially use a different funding model to decompress. So I mean, it's politically hot potato talking about using the private sector or third sector to help decompress, but I think that's what's required. And then also within the NHS, we find the bottleneck is, you know, we've created these MS centres of excellence, and they're the bottleneck, so people have to come through them to access services. And I would think we should create what I would call self-management pathways, where people can do what they can themselves, and if they can't get the answer right, they go off straight, bypassing the MS centre for the specialist investigations and treatment, like going directly to continence people for bladder and bowels and sexual dysfunction, going to the podiatrist for their foot health, going to the physiotherapists if they've got problems with balance, walking, falls, etc. So you create these, and you, and as I was saying to you, you know, putting in self-referral pathways, you need to get the whole NHS to agree to it first of all. You know, if you just get the speech therapist saying, I'm not prepared to let an MS patient self-refer, they've got to come through the MS team, well, that just defeats the point of the object. You know, somebody's having choking episodes and swallowing difficulties or speech difficulties. why should they go through the neurologist, their GP, or the nurse when they can go straight to a speech therapist, for example? So you're going to have to reconfigure the whole NHS around that. And I think that will help decompress and get rid of the bottlenecks. It's just an idea of mine. But I don't think every person with MS, though, feels comfortable enough. And this is why you're going to have to, you're going to have a training course. You're going to have to, and this happens in other disease areas. Which is, if you've got type 1 diabetes or even type 2 diabetes, you're expected to do a lot on your own outside the NHS. I don't see why we can't use that model for multiple sclerosis.
Yeah, excellent. I think if you are a policymaker, if you are one of the directors at Trust and you're listening to this, I think rethinking, reshaping, and providing different models of funding, different models of care is the way forward. Let's move on to other questions, and we're sort of coming to the nearly conclusion, to be honest, and we have a few questions in the audience. Just whilst I'm picking up some questions from the audience, what's the future like in MS, and anything that is coming next in MS research and treatment? Maybe, Jeremy, are you aware of any future innovative approaches?
Am I aware of any innovative approaches?
Maybe AI could help us to diagnose people with MS in advance, or some other digital technology tools.
I'll tell you why. I was trying to manage the chat as you were talking, which I can't. But I would just highlight one thing I came across recently, which was some work done in the US. In the knowledge that there is a hereditary component to MS, they are actively investigating the blood relatives of people with MS, and they have then they do this usually through MRI scanning, and they've got this little portable MRI scanner or scanners around the place that they can take to people, so that they can have scans in near them. They get enough sequences from these scanners to do a screening method for picking up people who have asymptomatic disease and may go on to develop MS. And it was really interesting and heartening to see that very proactive approach to trying to identify people, in the knowledge that there is a hereditary component, and B, we're increasingly recognizing that MS has an asymptomatic phase during which a disease process will develop, but people will not have any manifestations. And that in the early stages, the manifestations are often atypical than those that might be expected classically. And so we need some ways of lowering our threshold for identifying MS if we're going to make that massive change to the natural history. So the first step of change is the treatments that have, without doubt, radically changed the natural history. But the next step is that very early identification. And of course, the third step, which Gavin may want to come into, is prevention through vaccines.
Gavin, yes, so we would like to hear more about the vaccination, EBV vaccination, that could potentially prevent people from developing MS. What's the future like on this?
Well, I think it's really exciting, because Epstein-Barr virus, the virus that causes glandular fever or infectious mononucleosis, is necessary to develop MS. So people who don't have the virus don't get MS. So, and that's now been confirmed in quite a few studies. So the virus is absolutely necessary. So if you prevent people getting the virus using a vaccine, you may prevent people getting MS, and there are other autoimmune diseases as well. So that's going to happen, and the vaccine is being developed by several companies, and the idea would be to start off, I think, in teenage children, vaccinate them to prevent infectious mononucleosis, because IM is an unpleasant illness, and maybe that will prevent MS. That's the theory, and we'll have to see what happens. And that's the development pathway for vaccines. But just treating infectious mono, so infectious mononucleosis, which is the symptomatic phase of EBV infection, that's when you get these terribly sore throat, large glands, and you feel terrible with lots of temperature and fatigue. And some people have to miss months or even years of school and university because it's so damn severe. Just treating the infection may actually reduce the risk of MS, because something happens during IM to the immune system that then primes it to develop MS in the future. So if you can treat the infection with an antiviral drug, for example, and get people over like an antibiotic for bacterial sore throats, an antiviral for EBV sore throats, we may be also able to prevent those. So those are the two pathways going forward for MS prevention: a vaccine to prevent getting infected in the first place, and then a treatment for IM to helpfully reduce the time people have got symptoms. There's an analogy to that. People may not know this because this is a disease that's disappeared, but right back in the 1940s or even before, people used to get streptococcal, sore throats. And if we didn't treat them, they used to get a condition called rheumatic fever. And once antibiotics came available to treat streptococcal sore throats, rheumatic fever disappeared. The same thing may happen with infectious mono. So those are the two exciting areas of research there.
Wonderful. Thank you. So questions from the audience. The one that I just picked up is very reasonable. And what would be the minimum follow-up period for establishing a diagnosis of smoldering MS? Could that become practical enough to allow implementation in prospective trials? Thank you. Anybody that...
Well, so with Jeremy's work. Yeah.
What would be the minimum time? Well, that's very difficult, isn't it? Because people have such variability in their symptoms. I guess that what has happened for logistic reasons for clinical trials is people would talk about 2 years free of acute activity and progression over that period of time. I mean, diagnoses of progressive MS try and talk about somebody having progression over a year. But I don't know how I'd answer that question about the minimum time. I'm sure it's much shorter, and it depends on stages in the disease, and it also depends on where you are in that, because there are two issues. There's rate of change, and then there's also thresholds of change. So it's a bit like, I guess, your washing machine can get worse and worse and worse, and then suddenly it stops. And the little bit that it takes to stop is a tipping point. And it's the same, I think, with disease processes. They're not linear. They progress in different ways because the manifestations have different impacts on people. So you have the difference between what we call quantification and then the qualitative implications of that. I know that doesn't really answer the question.
So in clinical trials, the PIRA, you've got to have, most people use the 3 months confirmed. So you're talking about at least, it's probably at least 6 to 9 months to confirm those things. Because there's a question in the Q&A by Ayad saying, isn't it just progressive MS? Yes, it is. Smouldering MS is progressive disease. We just don't like to call it progressive disease because it means two different things to people when we talk about progressive disease. But again, the criteria there are 12 months, essentially, over 12 months. Yeah. Very difficult to make a diagnosis of worsening MS in anything less than 6 months, and ideally you want it to be 12 to 24 months.
Wonderful. Maybe the last question, if smoldering MS is the main driver of disability and start early pre-diagnosis, why is there still a distinction between types of MS that preclude people who still also have active MS from trials for progressive MS? This is a good question.
That's a very insightful question. Jeremy and I, we sit on the same side of the fence here. We want to get rid of the terms progressive MS, because MS is MS, and then you have descriptors, and what, the process is happening from the beginning. And the reason why you don't have overt worsening is because you've got resilience. You cope with the loss of axons or disability because you've got spare capacity within your nervous system. And then when you run out of reserve, then you get progressive disease. But that process is there from the beginning. So I think a much better way of talking about it is you have MS, and then on top of that, you have the descriptors. Is there any evidence of inflammation, relapses, and focal MRI activity, new lesions? Or do you have any evidence of worsening, be it early or late in the disease? It makes no difference. It's the same process.
Yeah,
I think we're going to. I think we're going to move there. I think the field will get there eventually.
Yeah. Yeah. It's one disease, isn't it? Yeah.
One disease.
Yeah. One single. A couple of questions on lifestyling, so maybe I'll take that. One is caffeine and alcohol that can worsen smoldering MS? Well, everything is with moderation. If you are exposing yourself with the energy drinks full of caffeine but full of sugar at the same time, so that's going to cause obesity and overweight. So it's no. If you are exposing yourself with alcohol daily, that's going to be toxic to your liver and your brain health. So alcohol in general is toxic to your brain. So it can cause premature aging process. So avoid that. Have some alcohol over the Christmas, but then have days no alcohol. That's the better way of managing your general health, your heart, your lungs, and your brain health. And is the fasting a good management of MS? Intermittent fasting is proven to be a wonderful approach to. It's actually anti-inflammatory. There's different aspects that works very well. So insulin resistance, it works via our hormones, and it's an effective way of losing weight and having anti-inflammatory effect on your body overall. And it works in MS. We have some emerging evidence. Beside that, intermittent fasting, you have to think about what age you are. If you're a young woman, childbearing age, try not to exceed more than 14 hours of fasting, because it can slightly change your menstrual cycle. So be mindful, explore, maybe start with 12 hours only. And then there are other diets being studied in multiple sclerosis, which is ketogenic diet, one of them that shows some evidence that helps in MS. We don't know how much of that is emotion, how much of that physical activity. When you are exposing yourself with a good quality home-cooked diet, you feel much better. Your symptoms are milder, and overall quality of life improves. So yes, so these kind of quick answers to your questions, and I think we have to now start wrapping up, because it's 1 minute till 6 o'clock. I want to express my deepest gratitude to Professor Gavin Giovannoni and Professor Jeremy Hobart for sharing their expertise, insights, and of course, time. Time is super important. Your contribution continue to inspire progress and innovation in MSK is excellent and wonderful. We are all having now hope after this 1 hour. And to our audience, thank you for your thought-provoking questions, engagement, participation, making your time this evening, and your voices help us identify the what truly matters in multiple sclerosis care as well as research. And if you have any further questions or feedback, please feel free to reach us out. We are on LinkedIn, on various different media channels. We also send you invites via Andrea. Andrea sends you emails, so you can come back to her. This is just one single step in an ongoing conversation. We just started, and we look forward to more opportunities to collaborate, to share knowledge and information. Jeremy Hobart is going to share his slides. Oh, he can't share. Maybe Andrea could share. So Jeremy, email to Andrea whilst I'm talking the slide, and Andrea is going to share how to get involved into the Professor Jeremy Hobart research project, looking at identifying what is like living with smoldering MS. And on the behalf of the Southwest MS Research Delivery Network, thank you so much, as well as on behalf of NAHR, helping us to provide this platform for people to come and learn in real time. So everyone, take care. and have a wonderful, wonderful, sparkling, magical Christmas and New Year. And we will see you next year then.